Hi, everyone. Welcome to the Asian Cancer Resource and Support Services Health Talk for the month of June. My name is V. I am the Vietnamese Cancer Patient Navigator with the Asian Cancer Resource and Support Services, or ACRSS for short. So before we get started, I would like to give you a brief overview of what ACRSS is. ACRSS is the first ever Asian Cancer Resource Center in Oregon that aims to address the full cancer continuum, ranging from prevention, screening, treatment, to survivorship support. We serve clients in Cantonese, Mandarin, Korean, Vietnamese, and also English, as seen by our brochures here. Our goal is to increase the culturally and linguistically appropriate cancer resources, educational materials, and support. To learn more about our services, to view, download, or even share our brochures and information with your friends or community members, please visit our website, which is listed right here. We also have a YouTube channel, which we share many of our health talk presentations, cooking demonstrations, and also other fun activities that we did. Please feel free to check out our channel. And you can do so by typing this name right here into the search bar. And with presenters' permission today, we will also be recording and sharing the recording of this presentation on our YouTube channel. We also have some housekeeping items that we would like you to be mindful about. First, this presentation will be recorded for future training purposes. So we will turn off your camera and mute your microphone to reduce disturbance during this presentation. And because of that, we suggest that you type any of the questions that you may have in the chat box, and we will gather all of them at the end and have a Q&A. Please note that at the end, during the Q&A, we will unmute your microphone and turn on your camera so that you can share your questions, and we will also stop the recording once we start the Q&A portion. This presentation will also be shared on our YouTube channel, so if you are interested in viewing the PowerPoint slides again, you can find the recording on our YouTube channel. And on a side note, our presentation is scheduled to run until noon today, but our presenter will continue to stay with us until 12:30 to answer any lingering questions. So you are more than welcome to stay with us until then, or you can leave if you need to. And with that said, I would now introduce our presenter. Today, we have the honor to have Dr. Anthony Van Ho. Dr. Van Ho specializes in hematology and medical oncology with subspecialty expertise in lung cancer, gastrointestinal cancers, and benign and malignant hematology disorders. He is widely known for the support and comfort he provides to patients and their families throughout treatment. Dr. Van Ho is a strong advocate for interdisciplinary care designed to ensure a dedicated team of experts is there to benefit the patients in every positive way. In addition to his busy practice, Dr. Van Ho is passionate about collaborating with nonprofit organizations to provide oncology support in the community and speaking at educational conferences, as well as helping to spread awareness about local resources. In his spare time, Dr. Van Ho enjoys singing karaoke, swimming, kayaking, and stand-up paddling. Please help me welcome Dr. Van Ho.
Thank you. Hi, everybody. Again, my name is Tony Van Ho. I am a medical oncologist at Compass Oncology, practicing in the Vancouver and Portland metropolitan area. I have been in practice for about 20 years, and my main interest is lung cancer, and I am bringing to you today a talk on lung cancer. Also, I am bilingual. I am fluent in Vietnamese in terms of reading, writing, and speaking, and of course, English. So with the first slide, please. So like I said, I started my oncology practice about 20 years ago. So to compare and contrast, 20 years ago, when it comes to lung cancer, we did not have much knowledge about diagnosing lung cancer or treating lung cancer. At that time, when a patient is diagnosed with lung cancer, especially with advanced stage disease, we really did not have many treatment options for them. For example, if patients had a lung cancer diagnosis and they were very ill, we would recommend comfort care in the terms of hospice care. And in that scenario, Patients typically live for approximately 2 months or less. For those patients diagnosed with advanced lung cancer, the only treatment available at that time was chemotherapy if they were candidates for treatment. And even with chemotherapy, we did not have many options for chemotherapy drugs. So that was 20 years ago. Going forward to now, there has been many advances in lung cancer in terms of diagnostics, procedures, and treatment. And so that is why I'm highly passionate about the field of lung cancer. Next slide, please. So just to give you some statistical analysis about lung cancer within the last 5 years. How common is lung cancer? Lung cancer is the second most common cancer in the country. It is second to breast cancer in women. So there are about 225,000 cases of lung cancer diagnosed each year in the United States. It is more common than colon and rectal cancer. It is more common than prostate cancer in men. It is, however, the most lethal cancer. So as you can see on the far right-hand side column, there are about 160,000 deaths per year from lung cancer. That is 4 times more than deaths from breast cancer. It is 7 to 8 times more than deaths from prostate cancer. It is about 3 to 4 times more than colorectal cancer. So as you can see, based on the number of deaths from lung cancer, it is a major health issue that we deal with on a day in and day out basis. Next slide. What about statistics in the Vancouver and Portland metropolitan area? So each year we see about 1,100 to 1,200 cases of newly diagnosed lung cancer in this region, and I see a fair share of these patients. Next slide. Lung cancer patients present typically at an older age, usually associated with smoking cigarettes, but not always. About 1 to 2 out of 10 patients diagnosed with lung cancer are never smokers. And so we do see patients that are never smokers with lung cancer. Cigarette smoking is the most common cause of lung cancer. The second most common cause is radon exposure. Radon is a gas that some people get exposed to living in basements and whatnot, but there are other causes of lung cancer. Lung cancer affects various racial and ethnic groups: Caucasians, African Americans, Asian Americans, Asians, Native Americans. They have additional health issues such as underlying emphysema, underlying which does indeed pose a problem for patients and for doctors. They present with substantial symptoms, including shortness of breath, coughing up blood, chest pain, weight loss. So those are some of the few symptoms that I see when I see my patients presenting with a new diagnosis of lung cancer. Next slide, please. So before understanding lung cancer, I just want to go through an overview of the lungs as a set of organs. The anatomy for the lungs, on the left side, the left lung contains 2 lobes. On the right side, the right lung contains 3 lobes. So the body is asymmetric in that way. The trachea, or the windpipe, brings air into the left lung and the right lung via the left bronchus and the right bronchus. And as you know, air is important because within air there is oxygen that is extracted by blood vessels in the lungs, and oxygen is then delivered to all tissues and all organs in your body, the brain, the muscles, the skin, the organs, etc. Pleura is another anatomical structure of the lungs. The pleura is basically the lining around the lungs. It separates the lungs from other organs and other tissues. Then you also have lymph nodes in the chest cavity. Lymph nodes are basically a filtration system that filter out junk in your body. So lymph nodes filter out viral infection, bacterial infection, and so on. So lymph nodes are important to have. So when we talk about how do we assess the anatomy of the lungs, doctors can pursue initially a simple test such as a chest x-ray to look at the lungs, to look at the airways. And on the chest x-ray, your doctors may detect an infection such as pneumonia. They may detect fluid buildup in the lung. They may detect a mass, which becomes concerning for lung cancer. And when there are things that need to be evaluated further from the chest x-ray, the doctor may obtain then a CAT scan or a CT scan of the chest. A CT scan gives you more information. So for example, if there is a mass in the lung, the CT scan will look at the mass in terms of what is its size, what is its shape. Is it an inch big? Is it 2 inches large? Is it oval? Is it round? Is it triangular? And so on. Are the lymph nodes enlarged? Is there something wrong with the pleura tissue that we just talked about? So those are things that we can gather from a CT scan of the chest. A PET scan is yet another scan, and it is somewhat different from a CT scan. Like I just said, a CT scan or a CAT scan looks at size and shape of an abnormality or a mass lesion. A PET scan looks at intensity of a lesion. Is it hot? That becomes concerning. Or is it cold? That is suggestive more of a benign lesion. So on a PET scan, we looked at a lesion to see, is it bright, like intensity of the sun, or is it cold? Again, if it's bright or if it's hot, that becomes concerning for cancer. If it's cold, then we are more comfortable that it is more of a benign lesion. Bronchoscopy is a procedure that is done by a lung specialist called pulmonologist. It is a camera that they look down your airways into your lung tissue to see if there is any mass lesion or any evidence of infection. So that is another method that we can evaluate the lung anatomy. In the middle column, I'm talking about the lung function. So when you evaluate the lung for its anatomy, you evaluate the lung for its function. The lung's function is primarily to bring in air, and air then provides oxygen to the body. So the lungs provide the capillaries in the lungs to exchange oxygen and carbon dioxide. So capillaries go through the lungs to drop off carbon dioxide and extract oxygen and bring the oxygen to all the important tissues in your body, a very important function that the lungs provide. On the next column, we're talking about lungs biology or molecular biology, okay? So lung or the tissue of lungs is made of different cells. There are different types of cells. For example, glandular cells are cells that are glands that produce mainly mucus. Mucus is very important because it provides lubrication, and mucus also provides a protective mechanism against infection, for example. So mucus is extremely important. Squamous cells provide traction for airflow in and out of your lungs. Neuroendocrine cells are cells that provide your lungs with the day-to-day metabolism. Mesothelial cells are cells that line the lining of your lungs. Again, those linings are called the pleura. So the pleura contains mesothelial cells. And there are other cells in your lungs, blood vessel cells, blood cells to support the immune function in the lungs, muscle cells to help the lungs contract. So lungs have these cells that are very important to look at, and when the cells become abnormal, the abnormality could be cancer. And so it's very important to look at these individual cells, and to look at these cells, typically it is via a biopsy. Biopsy can be done by various ways. The patient can be seen by a lung specialist where they put the camera down the airway and get a biopsy that way. A biopsy can be done by an ultrasound. A biopsy can be done via a CAT scan. So a patient may go back into the CAT scanner to localize if there is an abnormality in the lung, and the radiologist will biopsy that abnormality. A biopsy can be achieved by a surgeon. So sometimes I refer my patient to see a surgeon, and the surgeon will do an incision of the chest to get me a biopsy. So all those methods are viable in order to look at, is there an abnormality of a tissue, more specifically, any abnormality of a certain cell type. Next slide. So when it comes to cancer, cancer comes from different cell type that we just talked about, okay? So if the cancer comes from the glandular cells that we just talked about, the mucus secreting cells, that cancer is called an adenocarcinoma. It's the most common type of lung cancer in all races. It's the most common cancer in smokers and in non-smokers. The next most common cell type for cancer formation is a squamous cell. A squamous cell, again, is a cell that helps traction of airflow in and out of the lungs. They can become cancerous, and that is the second most common lung cancer. So adenocarcinoma, squamous cell carcinoma, and other larger types of carcinoma are grouped together as what we call non-small cell lung cancer, and that's abbreviated there. Then last but not least, is a smaller type of cell that are neuroendocrine cells. These cells are, they serve as the day-to-day metabolism of your lungs. If they become cancerous, they are called small cell lung cancer. That represents about 15% of the group. So for today's discussion, I will focus more on the more common lung cancer that is called non-small cell lung cancer, that again represent 85% of lung cancer. Next slide. So lung cancer is diagnosed at various stages. We typically prefer, if the lung cancer is diagnosed, we want to see patients at an earlier stage of disease where treatment can be curative. And so that is stage 1 or stage 2 lung cancer. But we don't see stage 1 or stage 2 lung cancer as commonly as we diagnose patients with stage 3 or stage 4 lung cancer. Unfortunately, when a patient is diagnosed with stage 3 or stage 4 disease, that is more advanced than earlier stage disease, so the prognosis is less favorable and the treatment becomes more advanced, more complicated. So what are all these stages? Stage 1 is typically a small mass in the lung, and that's all there is to it. It's just a small mass that is cancerous. And treatment is typically surgery to remove that mass, and that is all there is to it. Stage 2 lung cancer is when the mass becomes slightly bigger, but it has not gone anywhere else. And stage 2 means a larger mass that still can be treated with surgery. You just take the cancer out surgically. And a lot of times that's the only treatment that a person needs. Stage 3, on the other hand, is when the cancer has gotten bigger and has spread to those lymph nodes that I talked about. Cancer can spread to lymph nodes in the chest. And when that has occurred, that is called stage 3. When the cancer has approached stage 3, unlikely surgery is the treatment of choice. By that time, the cancer has gotten more advanced, and therefore we involve radiation treatment into the treatment paradigm. Stage 4 is the most advanced, and that is when the cancer has spread to other organs of the body. Lung cancer likes to spread to the liver first and foremost, bones second, adrenal glands third. Adrenal glands are glands that sit on top of the kidneys. And then fourth, the brain. There are other organs besides those 4 organs, but those are the 4 most common organs that lung cancer like to spread to. Next slide. So again, when it comes to treatment for lung cancer, we divide treatment recommendations based on what is the stage of the lung cancer. Early stage disease is typically treated with surgery if the patient is a candidate for surgery. If their health does not make them a candidate for surgery, sometimes we just radiate the mass lesion. When the cancer becomes advanced, then my role becomes more important. My role is to provide the patient with advanced lung cancer with drug therapy. And drug therapy comes in the form of chemotherapy that has been around with us for many decades. Drug therapy can involve targeted therapy and immune therapy that I will discuss for the remainder of this meeting. So targeted therapy and immunotherapy are newer drug therapy that we have studied and have developed over the last 10 to 15 years. And that is a very profound discovery for scientists and for doctors. Now, lung cancer therapy is also important when you look at supportive therapy. We support patients for their symptoms. We try to control their cough. We try to control their pain. We try to control their nutrition or manage their nutrition to prevent weight loss. Survivorship, as you heard earlier, is important. Palliative care is important. So supportive care is extremely important as we move patients along with their surgery or their radiation or their drug therapy. Next slide. So first, I will talk about targeted therapy. So what is targeted therapy? The American Cancer Society describes targeted therapy as cancer treatment that uses drugs to more precisely identify and attack cancer cells, usually while doing very little to your normal healthy cells. Okay, that is in stark contrast to chemotherapy. Chemotherapy is less precise, less specific. Chemotherapy will attack your cancer cells, but at the same time can affect your hair cells. That's why people lose their hair. It can affect cells of your gut. That's why some people have nausea and vomiting. So targeted therapy has improved in that sense that it is more precise, more specific. Next slide. Again, going back to 20 years ago, if I were to tell you about lung cancer 20 years ago, this is a slide that I would have. What do we know about non-small cell lung cancer? This is an empty box that I'm showing you here. We didn't know much about lung cancer, but since then, knowledge has been formed to give us so much more to discuss about lung cancer. That takes us to the next slide. So the box that I'm showing you here is a knowledge that we have gained over the last 15 to 20 years. What is this slide all about? This slide tells you that we can identify genetic markers or molecular markers that have become mutated on a normal lung cell. And these mutations then take a normal lung cell to become a cancerous lung cells. So this is a slide that depicts so many mutations in the lung cancer cells that we have identified over the last 15 to 20 years that provide us with information in order to treat the lung cancer in a more specific way, as opposed to non-specific like chemotherapy. Next slide. So if I were to describe to you, okay, what is an example of a molecular mutation? This is one example of a molecular mutation. We call it the EGFR mutation. So EGFR is normal to begin with. So my lung tissue should have a normal EGFR molecule. It is there so that when the body needs a new lung cell, it stimulates the EGFR molecule so that a new lung cell can be made and duplicated and grow. That is all a healthy environment. But for someone who gets cancer, their EGFR molecule becomes mutated. The mutated molecule then becomes a problem. The mutated molecule stimulates itself to duplicate itself, to grow, to divide, and to spread nonstop. Okay, so one cell becomes two cells become four becomes eight becomes 16, then 32, then 64, and so on. Over time, that cell becomes logarithmic, exponential in number, and therefore it becomes a mass. And that happens nonstop. And then it also spread to other organs. That is the problem of cancer. That is the problem of a cancerous mutation. So we have identified EGFR mutation as well as other mutations. And by having that knowledge, we are able to develop treatment toward a particular mutation. So for this EGFR mutation, the picture there depicts the molecule on the cell surface. And if this molecule stimulates its own self to send signals into the cell and stimulate the DNA or the genetic information inside the cell, that will then create ways for the cells to duplicate, grow, divide, and spread. So that's what this picture is trying to depict. Okay, so knowing this information, what we want to do is block that molecule on that cell surface. Next slide. So how common do we see this type of mutation? This EGFR mutation we see in about 10% of Caucasian patients with lung cancer. Contrast to that, we see about 50% of this mutation in Asian patients with lung cancer. A big difference. They present themselves, the mutation presents itself more in female patients than male patients. It presents itself in never smokers as opposed to heavy smokers. It typically presents in an adenocarcinoma, which is a cancer of glandular cells as opposed to other types of lung cancer cells. Okay, next slide. So I'm going to present to you this clinical case. This is a patient of mine. She is now 50 years old. 8 years ago, I met her when she was sent to me by her primary care physician. She came to me with a history of a cough for 6 months, enlarged lymph nodes in her neck, and she was found to have an abnormal chest x-ray that was obtained by her primary care physician. So when she saw me, I sent her for a CAT scan or a CT scan, which is on this slide here. So on this slide, you can see an obvious mass in her right lung that is depicted by an arrow. That is abnormal. That is a lung mass. So she was also found to have other areas of cancer. It existed in her neck via an abnormal lymph node. It was in her bones. It was in her spine. So she was diagnosed with stage 4 disease, meaning this lung mass in her right lung has spread to her neck in a lymph node and her bone in the spine. She was sent for a cancer biopsy and it came back showing an adenocarcinoma, which means it's a cancer affecting the glandular cells, the cells that make mucus. I studied her lung cancer pathology further, and I found that her cancer carries this mutated EGFR molecule. So with that information, the treatment is to stop this mutated molecule from causing problems. And so the treatment for that is to give her targeted therapy, meaning give her a pill that she takes daily, every day, and that pill will localize to this mutated molecule and stop the molecule from doing its bad business. So she started that medication 8 years ago. Next slide. This is the discussion and the picture showing again that mutation. And if you give the patient medication, it stops the molecule from doing the signaling into the cell, stop the lung cancer cell from duplicating, dividing, growing, and spreading. And there are different medications with the brand names I'm listing here. You don't have to know the names to be exact, but that's what we typically do. The medication comes in the pill form that you take daily by mouth. Next slide. So here is my patient. The picture on the left is again her lung cancer mass that is glowing on a PET scan. And then on the right is the result of her having been on treatment for 3 months. This is a scan done 3 months later. So on the left, you see a very active lung cancer mass. On the right, you see almost complete disappearance of that mass, which is amazing. And her symptoms improved during those first 3 months that she started treatment. Next slide. This slide showed on the left is her abnormal lymph node in the neck. This is a portion of the scan that depicts the neck. She came in to see me with enlarged lymph node in the neck, and you can see that glowing on the left side. 3 months later, after having been on treatment, you don't see that enlarged lymph node anymore. You don't see an active lymph node anymore. Her neck came back to normal size. Again, an amazing response. Symptoms went away, patient felt better, scans look better. And so that is an example of the success of targeted therapy. Next slide. Targeted therapy in the form of taking these pills is generally very well tolerated, much better tolerated than chemotherapy. Some side effects that patient may have would be a rash, which looks like acne on the face. It's very manageable. They may have diarrhea, which is also manageable. We would advise our patients to take over-the-counter Imodium or an anti-diarrhea medication to stop the diarrhea. It typically works. Rarely, it can cause nausea. Even much rarer, it can cause inflammation in your lungs or inflammation in the liver. And we typically follow liver enzymes in terms of laboratory evaluation every so often in these patients. Next slide. Now, targeted therapy is very, very effective, but it doesn't always work long term. And the reason for that is that cancer cells can be very smart. They are intelligent cells, unfortunately. They will find ways to develop resistance. And they will find ways to develop resistance by the sense that they will make more mutations. They will make new mutations. And when that has happened, these new mutations overcome the old mutation, causing drug resistance. So the drug that the patient was on before may not work anymore. Surely that happened to the patient I just talked about. She was on a targeted therapy for 7 years. 7 years later, she developed resistance to the medication. Her cancer became active. So I had to take her off that medication, and she is now on immunotherapy, which takes us to the next discussion. So immunotherapy is different from targeted therapy. It is also very new in the lung cancer treatment realm. The American Cancer Society describes or defines immunotherapy as treatment that uses certain parts of the body's immune system to fight diseases such as cancer. It does so by stimulating the immune system to become smarter in order to attack the cancer cells, okay? Next slide. So for you to understand immunotherapy, I just want to give a brief history. Immunotherapy has been around for more than a century. So in 1890, there was a surgeon named Dr. William Coley Dr. Coley was a cancer surgeon. A lot of doctors referred patients to him because their cancer had spread to bones. So he was a bone surgeon, and he was seeing many patients with cancer that have spread to the bones in the arm, in the leg, in the hips, in the spine, whatnot. So in many cases, he can operate on those people. He can operate on cancer in the arm bone, cancer in the hip bone. But there were circumstances where the location of the bone cancer did not allow him to operate, and he got stuck with those cases. But one day he thought of an idea. He thought of, why don't we stimulate the immune system to take care of the situation? So what he did was that he injected a bacteria into the area of the bone cancer. And he thought that if you do that, then the body will create an infectious immune response to take care of the infection. The infection, again, is the infection that he injected into the cancer area. But if you get an immune response to that area, the immune response will take care of the infection and the cancer. And therefore, he found some success by doing that. He found that some people's cancer mass in the bones got smaller. And so that was the first case history of immunotherapy, triggering the body's immune system to fight the cancer for you. So since then, we have discovered immunotherapy in various ways, in various drug types, in various cancer. Until 2015, 5 years, 6 years ago, we got the first immunotherapy approved by the Food and Drug Administration. The FDA approved the first immunotherapy agent for lung cancer. Next slide. So let's try to understand the immune system. The immune system is a very important system for the body to fight against infection, cancer, and many different things. It's the body's natural defense against disease. The immune system has to be very smart to understand what's normal for the body and what's not normal in the body. It has to understand the distinction between normal cells in the body and abnormal cells that should not be in the body. Next slide. So the immune systems contain many different types of blood cells. These are white blood cells. They are called natural killer cells. There are other cells that are called lymphocytes, such as B lymphocytes or B cells, T lymphocytes, such as T cells. So there are many different types of immune cells to represent the body's immune system. Next slide. So in this picture, I want to depict what happens when you have the earliest sign of cancer in your body. When you have the earliest sign of cancer in your body's immune system will try to eradicate that. Okay, so on the left is a brown tumor cell. On the right is an immune cell, and this immune cell is called a messenger cell or a presenting cell. So the immune cell recognizes that there's a tumor cell in the body. That's not right. That's a foreign cell that should not be in the body. So it recognizes that it's a messenger cell, so it will deliver that information to, next slide. It will deliver that information to another immune cell. This immune cell is now a lymphocyte. So the purple messenger cell presents information to the blue lymphocyte, saying that there is a foreign cell that looks like a cancer cell in the body. Now go get it. So this lymphocyte is basically a police cell. It polices the body for something that is not normal. So after getting the information from the messenger cell, it activates itself. It gets more aware. Then it recruits other policing cells. Next slide. So it finds other policing cells and form a crew. So this is now becomes a police force to go fight the cancer cells. Okay, so that's very effective. Next slide. So this slide basically depicts the entire scheme. So you start out with an early cancer formation when there is one or two or a very few cancer cells in the body. The immune system finds that by the messenger cell seeing the cancer cell, bringing that information to a lymphocyte, which is the policing cell. The policing cell becomes more aware. It then goes form a crew of police force, and that will go target cancer cells early on. Okay, next slide. The problem, however, like I said before, cancer cells are very smart. They can find ways to overcome the immune system. So in the bottom slide, in the bottom picture, the cancer cells here forms a shield or a barrier around itself so that the policing cells, the lymphocytes, do not recognize it as a cancer cell. On the upper picture, the cancer cells also form a shield between the messenger cell and the lymphocyte so that there is no communication between the messenger cell and the policing cell. So these barriers are secreted by the tumor cells to protect themselves from being destroyed by the immune system, to favor their environment so that they will have a chance to duplicate, divide, grow, and spread. Hence, that's the problem. The immune system is put to sleep. The immune system is no longer recognizing that there are cancer cells in the body. So over the last 15 years, we have been studying this mechanism, and now we do have treatment for this kind of process. The treatment is basically disrupting this shield, breaking away this barrier, waking up the immune system and telling the immune system that there are cancer cells in the body. Now go get them. Okay, next slide. So the barrier is called a checkpoint. So that is the term that we use in lung cancer therapy. It is a checkpoint between the lung cancer cells and the lymphocytes, between the messenger cells and the lymphocyte. These barriers are called a checkpoint that the cancer cells have formed. And so we want to break down the checkpoint. We want to inhibit the checkpoint. We want to break the barrier. So there are IV medications. So these are medications infused into the body to break down the barrier. And these are the names of some of those IV medications. And that has now become the new standard of care for non-small cell lung cancer. Next slide. Immunotherapy is generally well tolerated. Again, it is not chemotherapy. It is an IV infusion of the drug to stimulate your immune system to respond to the cancer. It causes some fatigue or tiredness, and that is because your body is now triggered to work hard to pose an immune response. When your body works to stimulate immune cells, it does get tired. Immune therapy can sometimes cause a rash. It can cause diarrhea. These side effects are very manageable. Sometimes it can cause body aches in the joints. Rare side effects include inflammation of the lung, liver, colon, and these are all side effects that we follow very closely. Next slide. So I will present to you a case that is also a patient of mine. This is a man who presented at the age of 46. He has a history of 30-pack year smoking. He presented to me with shortness of breath and a cough and weight loss. And he was sent for a chest x-ray. So you can see on this chest x-ray that there is a mass in one of the lungs. So that is the whitish density there on the left side. Yes, that is a mass. That is abnormal. Next slide. So on the left side of the screen, that is a CT scan showing the mass that we learned from the chest x-ray. So we biopsy his cancer, and we found that the problem that he has lung cancer, or one of the problems that he had with his lung cancer, is that there was this process in his body that his lung cancer cells were very smart. They were creating barriers between themselves and the lymphocytes. They were creating barriers between the messenger cells and the lymphocytes. And so we started him on immunotherapy or immune therapy. And after so many months of therapy, we looked at his scan. So on the right side, what you see is his cancer was melting away. His cancer was melting away from inside out. So if you see this mass, you see a dark spot on the inside. That's a cancer melting away. On the outside, that is still a rim of active cancer, but it shows that the cancer is indeed melting away, which is a success from immunotherapy. Okay, next slide. So in conclusion, treatment for lung cancer has evolved dramatically in its landscape, from chemotherapy to targeted therapy to immunotherapy. So all these treatments remain the mainstay of therapy, including chemotherapy. Some patients do not have the option of receiving targeted therapy or immunotherapy, so chemotherapy remains the treatment of choice. Having said that, target therapy and immunotherapy are very important breakthroughs for lung cancer specialists like myself. And that's important because the newer therapy represent more specialized treatment, more critical mechanism-based treatment, as opposed to non-specific treatment like chemotherapy. And those treatments are now the new standard of care approved by the FDA. Next slide. So as a lung cancer specialist, I just want to give you some education on the lung anatomy, what lung cancer is all about, and newer treatments for lung cancer. If you have any questions, please do not reach out to the team. We hope to detect lung cancer at an early stage as opposed to a late stage. Therefore, lung cancer screening is very important to me, especially for those who are at high risk with their smoking history. We want you to be more intelligent about your lung cancer diagnosis, and therefore always ask your doctors about information about your subtype of lung cancer, any molecular markers about your lung cancer that might be helpful for you to look at your treatment regimes. Current treatment availability for lung cancer stem from a lot of research and clinical trials that we do in lung cancer. So we always have new clinical trials or research for lung cancer. I have about a dozen of lung cancer trials that I put my patients on. So if you have lung cancer and you're interested in cutting edge therapy, always ask about lung cancer clinical trials. Last but not least, supportive care for patients and their family with lung cancer is highly important. So I am part of awareness groups and fundraising programs to support patients as well as cancer research to always make things better for our lung cancer patients and their families. Next slide. So this is me among my staff doing a 5K walk or run to support lung cancer patients and families and lung cancer research. And at this 5K walk or run, we also had patients joining. And so please ask me if you're interested in fundraising events and being aware of the resources that you have in this Vancouver and Portland community. Highly important. With that, I thank you. That's the end of my talk, and I will take questions.